But when parents bring their children into ED, when parents present to their community nurse, when parents call an ambulance, they are terrified. They are frequently tired. They are not at their best. None of us are. And they are not going to be as you would find them on their best day. So we know this, but we frequently forget it. And that's going to be one of the main points today. It's just remembering. The kid has been awake 1, 2, 3 nights, fevers, vomiting, coughing. Parents have been up for 3 nights. So no one's slept. Everyone's overwhelmed. Parents are absolutely overwhelmed. Plus they've been Googling, they've been talking to relatives, they've got conflicting messages already before they've ever got to you. So no one's happy. And they want to know what to do. But you're going to tell them something that they're probably also going to conflict with what they've heard from doctors, relatives, friends, overseas, ChatGPT, all of these things. So how do we get everyone on the same page? It's easy, you can see there's a lot of little minefields that get through there. It's not hard to do it very well, but it's very easy to stuff up. And once you've stuffed it up once, you basically have lost the battle. So, is this a soft skills thing, as my Asian colleagues might call it, not to my face, or is it a core skills thing? I think it's a core skills thing. Talking to anyone, trying to really get where they're from is core skills, especially parents. Can we have this in evidence-based? Absolutely. A study done only 2 years ago had the prompt, at any point in a child's emergency presentation or admission, they were asked this question repeatedly. Are you worried your child's getting worse? That's it. Just are you worried your child's getting worse? Any parents who said, or kids, who said yes to that, the child itself was sicker than we thought. They were 3 times more likely to go to ICU, 5 times more likely to be intubated, ventilated, and 5 times more likely to actually die. So it's not just soft skills, this is listening properly, asking the right questions, getting people on your team, or more likely you getting on their team, is beyond core skills for me. So the talk today, we're going to talk about common problems that you will find, that you will always see. How to actually manage expectations. I think expectations management, at least in med school, at least in the RACP college, was never actually taught like this. We always talk about more communication, more communication, more communication. And this is not about speaking Gudara. It's about actually trying to shape the message so it lands. I think the lawyers would talk about the difference between intent and impact, what you mean to communicate and what is received. The term I learned from a friend of mine who's an environmental engineer. So it's a term that I've rapidly picked up, and I think is something that we all try to do. But when we do it with a much better plan, we will absolutely nail it. And then gets a bit of speaking Gudara at the end. So, the basics, the TED Talk 3. 3 things to actually hopefully go home with. Good communication is essential for good outcomes. You can have the absolute best medical plan, emergency plan. You can give absolute best gold standard care to every guideline in the country. But if you are not on the same wavelength as the family, they won't do it. You have the best plan ever. But if they don't trust you, it doesn't matter how good your plan is. It doesn't matter what you're trying to achieve. It's not going to land. I remember when I was a very, very young doctor, before I looked like this, and I was in a 50-minute consult with a general paediatrician with the family, and they clearly left unhappy. And we had a bit of a chat about it. He said, look, mate, it's up to them. If they don't want to take my advice, then that's their prerogative. And that is autonomy. That is absolutely true. My thinking was, yeah, you've just wasted 50 minutes of your life. You just wasted 50 minutes of their life. And they're going to leave further unhappy. So it doesn't matter how good your plan is. You've got to have the parents on side with it. So not just telling them the what, it's telling them the why. Jargon is absolute death to good understanding. I'll go through that a bit more. A term that I use, premature reassurance. If you go in all guns reassuring, when the parents are still freaking out about their kid, it comes across absolutely dismissive. You know, you've got all these concerns, kid's fine. So it's the wrong way to go about it. Okay, so I know this is an emergency medicine conference, and you're going to talk to me and say, bloody hell, the first topic was constipation in kids. That's not emergency. And I'm not going to talk about that very long. I'm going to talk about fevers, which is a proper emergency. But the example of constipation, to me, kind of actually demonstrates how parents and families are set up to fail before we ever get to them. Imagine you have a 2 or 3-year-old little kiddo. Most constipations, there are some organic causes, but most constipations are functional. You know, they have a big long day, they forget to poo, they go to a poo, it's a bit bigger than normal, kind of hurt. Kids aren't stupid, that hurt, I won't do it again. So the next time they go to poo, they hold it in. So when it finally does come out, it's even bigger, even harder, like that really hurt, I ain't doing that. And so they clench their butt cheeks and now you have a completely constipated child. They go to the GP or they go to the pharmacist and the pharmacist says, over there's a whole lot of laxatives, go choose one. You go to the shelf, there's 9 different products. Basic rule of medicine, if there's 9 different medicines, there's clearly not one that works. If there was one medicine that worked, there'd be one. There's not one that works, so there's 9. And now they're going to say, have a bit of a laxative for a couple of days. How much? How long? No one knows. No one's planned. And then they're completely set up to fail. And they come to ED. You know, it's a constipated kid, but they come to ED desperate. The kid is screaming, the kid is holding their legs. Constipation makes you more at risk of vomiting and UTIs anyway. So everyone's having a horrible time, even though no one's done anything wrong. So managing constipation by going, this is what constipation is, this is how we manage it. I won't do that now, sorry. But it's very easy to do badly. No one did anything wrong. Go to the shelf, go to the pharmacy, go to the GP. Not anything wrong. But it just wasn't done well enough to land. The intent and the impact mismatched. But fevers. Let's talk about fevers, because that's the thing we're really going to see in ED, in the back of an ambulance, in community nursing, wherever you are. Febrile children are 20% of my workload. 20%, 15 to 25% of a paediatric unit's workload is the febrile child. We know that the fever's less than 5 days, that generally the kid has got a benign intercurrent viral infection. That's not what the parents give 2 shits about. Sorry for the language. Technically, the fever's over 38, my opinion, and you can get a whole bunch of ID physicians in a room, give them a few shots of cheap vitamins and boxing gloves, and they'll have a massive showdown about whether it's actually 37.5 or 38. I'm actually more on the 37.5 side. Personally, you can have physiological reasons to go to 37.4, teething, donor variation, monthly variations, but there's no real, outside the neonatal period, there's no real reason to go over 37.4. So I actually think a fever is 37.5. Does that really matter if it's semantic? No, what it matters is, it's not teething, something's happening. And our job is to just try and figure it out, or at the very least, figure out if it's serious or not serious. This is one of the reasons why people hate paediatrics. And that's fair enough. You've got this kid who's screaming, who's vomiting, who's febrile, and they can't tell you what's wrong. My point on this is, there's always a clue. There's almost always, I think the truly undifferentiated child, no clues whatsoever. I've met like 3 times in my career, and I'm very bloody old. You know, they might be drinking and not eating, so you look at the tonsils. They might be pulling at the ear, they might have a small rash. They probably started daycare 2 weeks ago. There's always a clue. So it's just having a bit of a chat, have a sit down. The exceptions to that are obviously the febrile baby, the neonate. Neonatal febrile guidelines, we're not going to go into it. It's a whole talk into itself. It's the least flexible guideline of paediatrics that there is. Fevers in little babies, it's lumbar punctures, it's suprapubic aspirates, it's IVs, it's admissions, etc. It's the whole works burger. Except now, it's a bit stuffed, because parents, when they're very concerned about their babies, they go and buy the fanciest, most expensive thermometer you can buy, which is the forehead zappy-zappy one. The forehead zappy-zappy one, I'm sure there's a better name for it, is a little better than a random number generator, in a lot of our opinions. Although we can actually sort of put a bit of predictable unpredictability in there. A good Turkish study looked at 150 kids and consequentially took all their temperatures all the ways, including the uncomfortable ones, and they found out that in babies, it will typically overestimate the temperature by about 0.6 of a degree. Because, you know, if you get a baby's hand and put it above their head, it goes to here. Their heads are freaking massive, huge amount of body surface area. So we'll overestimate their temperature by about 0.6 of a degree. So if you have a kid, and the neonate's temperature range is actually baseline quite high, 36.5 to 37.5, they miss a poo, they miss a nap, they're cranky. Parents say, oh, shit, they're cranky, I should take the temperature. They were sitting at 37.6. This thing's overestimated them to be 38.2. Well, do you put a needle in the bag or not? I'm not asking you to make that decision. I'm just asking you to be aware that if someone comes in with a febrile baby, yes, have all of the knowledge, or at least pull up the guidelines. RCH guidelines, Queenstown guidelines, New South Wales guidelines, they basically copy and paste. But just ask 2 questions. Why did you feel the need to take the temperature? You know, acute behavioural change hasn't missed 3 feeds, or we do it 3 times a day because we're first-time parents and we're anxious and we don't say that out loud. And how did you take temperature? Exilla's the gold standard. Forehead zappies don't stress too much. So the how and the why is actually very important with parents. when you have a kid with a fever, if you drill down to one of the main, I'm going to ask the question, what's the worst fear that a parent has when their kid has got a high temperature? 38, 39, 40, I don't really care what the number is, as long as it's not over 41. What's the parent's worst fear? Sorry? What's the fever going to do to the kid? What are they worried about? He's got a fever. Convulsions happen. Going to cook the damn brain. You drill down, every parent has that fear. Now we know that's not true. But if you came to me and said, here's my child, they've got a fever, and I'm worried, fair, and I say, don't worry about that. But straight away, kind of tense. I haven't spoken to you, I've spoken to the brainstem. The reticular activating system is kicked off because I've directly contradicted a belief that you've had in you that comes through generations and cultures all over the world, and I've directly contradicted your belief that you have been taught by all of your friends, relatives, and generations above. So if you just directly reassure someone, you've contradicted their long-held belief, their brainstem kicks off, their sympathetic drive kicks off, even though they don't really know, they're trying to listen, but they don't like you anymore, they're not going to listen to you anymore. So how do you actually have the fever talk? Because fevers are technically good for us, they help us fight infections. So, if you could drill down and go, don't say what you're worried about today, because that really feels dismissive. Of the things we're worried about, what would be your worst one? And they always go, oh, that's going to hurt. Yeah, sometimes a lot of people tell me that it's going to hurt the brain. Yes, exactly. Of course it is. Okay, cool. I hear that a lot. It's a really common belief. I'm not going to challenge it directly though. I'm going to displace the responsibility for that very common, very reasonable, but not true, belief onto somebody else's shoulders before I not attack, but correct it a bit. So when we were kids, maybe more me than you, because 6 years ago, you know, our mothers and fathers, our aunties and uncles all thought a big fever was going to cook the brain. Well, of course. Well, thankfully, in the last 46 years of paediatric research, we now know, a lot of we language, not you and me, a lot of we on the same side, we now know that's not actually true. So our mothers and fathers, aunties and uncles, they're all very lovely, but in this case, they're all wrong. Not you're wrong, not that, because that's how it feels, but they're wrong. Because technically, fevers are natural. What a great fucking buzzword, natural. Technically, fevers are good for us. Of course, when we have a big fever, it's like a feedback thing, our bodies make more antibodies, have a stronger immune response. And also, the reason number one why fevers exist, and the other reason why fevers exist, and this is, I'm not so patronising, a bit more theatric now in front of 200 staring faces, but the other reason fevers exist is because the things that make us sick, the viruses, bacteria, the fungi, the parasites, they like us the way we are. 36, 37. So if we go hot, it makes it harder for them to do what they want to do. So that's why fevers exist. So now that mum and dad were very lovely, but just not quite right this time, what do? Well, it really is only one question, is the fever talk. If the child is hot, but happy, playing with blocks, eating and drinking, that's great. Let the fever do its job, because we sort of imply the functionality of it. If the child is hot, but unhappy, well, that's panopneurofitide. So that's the main fever talk. That's 20% of my work every day. But as a paediatrician, I can do the 20% of chatting to families, as long as 5% is some sort of status epilepticus, status epilepticus, major trauma. I need to have something really fun to get through the other stuff. Now, febrile convulsions, someone did mention. That's the one other thing I think is an example of things we do very badly that aren't very hard to do well. I'm not going to go through the 6 main criterion, but we'll roughly mention the rule of 3s. But again, if anyone wants these slides, they are yours. So the rule of 3s. Febrile convulsions, really common. 3% of kids. 3% of kids will have one. Of those 3, 1 in 3 will have another. And of those 3, of that third, 1 in 3 will have another. Once you get to 4, it's not really benign febrile convulsions anymore. As usually in those sorts of kids, 6 months, 6 years, previously normal, they have got a fever. Quick question, is it how hot you get or how quickly you get hot that actually trips the fever off? There's the second one. it's a gimmick question, but the medical students all shit their pants with that one. All right. Where we snatch defeat from the jaws of victory, because we know this kid's going to be okay. We know they're going to have a normal neurological outcome. There's no real increased risk of seizures and epilepsy and that sort of stuff. But the parents have never seen a child have a seizure before, let alone their child. So if you were to ask a family, or 100 families, for example, did you think your child was dying in front of you? Roughly what percentage would say yes? Sorry? 90, exactly 90. 90% of parents thought their kid was dying in front of them. And this is one of the main points. So a lot of my trainees are ASIMs. I love ASIMs. I'm kind of half trying to be one all the time. And they go, oh, God, mate, your kids have febrile convulsions, super common, super safe, kid's going to be fine. We walk away. And everyone's calm as shit. Parents are sitting there vibrating onto another bloody existential plane because they thought their kid was dead. But they don't say it because we're bloody calm as hell. So they don't know, are they wrong? You know, like, is my feelings wrong? Like, what the hell just happened? So when I'm with these families and they're like, I'm like, hey, you know, when we do studies on this, we ask parents, how do they feel? And 90% of parents who've gone through what you've just gone through actually say, I thought my kid was dying. They go, yes, absolutely, right. Because there are all these other things, like anorexia, insomnia, a third. These aren't kids, these are parents who can never eat again. They're parents who can never sleep again. I said, okay, knowing that you've just had the worst experience of your life, years taken off, how the hell can I look you in the eye and then tell you it's going to be okay? It's because, you know, little Johnny, little Fatma, Ahmed, whomever, has ticked all these boxes. And because it's 3%, we know it's so common. Thankfully, the only good thing about it is that we know a lot about it now. So because all the boxes have been ticked, I can look in the eye and tell you that the long-term outcomes are the same as for all these other kids. As an example, my wife had a febrile convulsion when she was a kid. She's a powerfully intelligent woman. Attitude could be a bit... Yeah, she's talking tomorrow. She's the lawyer. She's giving the law talk tomorrow. So I think, what are people all scared of in healthcare? Children and lawyers. So between us, we've got this shit locked down. So, but she's a fabulous speaker and it's going to be really good talk. And tick that off, I can say that. All right, so be sure of if you don't know the criteria in your head, I bash my trainees to know it because you've got to be able to look the parents in the eye and say why you're reassuring them, not just that you go in reassuring. All right. So, expectations management. This is really important. This is something that we don't do well. A reductive thing that you probably have heard is to, under-promise and over-deliver. Well, I think that's just as bullshit as anything else. What will people ask you in ED? How long will these bloods take to come back? You don't have to lie, or Rosie, just tell the truth. On average, about 90 minutes for these blood tests. However, sometimes they'll get slow, and if I'm doing something, I won't actually be free to check them and come and talk to you. So if we're really lucky, it's going to be 90 minutes. If we're not lucky, more often than not, it's probably closer to 2.5 hours. So I'm sorry about that. It's open, it's honest. They understand that. You're not trying to blow smoke up anyone's backsides, but you're just being extremely transparent. People aren't stupid. They're stressed, they're tired, they're not mentating very well, like they would on their best day, but they're still not stupid. So they just need to be told plain things in plain language. Bringing it back to paediatrics, abdo pain. Fever is 20% of my workload. Abdominal pain is 10%. 1 in 10 kids I see is abdo pain of some description. So again, frustrating as hell. Don't read this closely. This is just an example of what the parents are trying to figure out when their kid has tummy pain. It's way too much. So tummy pain is common. What do we know about tummy pain? We know that, again, if you line up 100 kids, and this is exactly how I talk to the families about this, if I line up 100 kids with tummy pain, which is 10% of my workload, that's why I look like this, and I do every test, because they all want the bloods and the ultrasound scan. If we do every test ever invented by humans in laboratories, every urine test, every blood test, every ultrasound scan, every CAT scan, MRI, X-ray, everything, we will have an answer. Your child has X. Half the time. Which means half the time I can do everything right, every test ever, and I will still not know what is going on. So when I practice this with families, with you guys, when I teach this to my training doctors, this is the one time when I go in and I'll do a completely arse backwards. This is the one time when I walk into a room and I do not want to know what is happening. I want to know what is not happening. Because if you have a mental list in your head of what can be happening, and you tick basically all the bloody boxes, and they've just got a sore tummy. And that's okay. So, but you start the conversation with 10% of my workload is this, or however part of your workload it is where you work, and half the time, despite every best intention, every best test, there is never an answer. The silver lining of that dark, frustrating cloud is the pain will generally burn off. We don't know what it was, but the further it is in the past, the less relevant it becomes. So that is probably one of the best examples of expectations management in modern medicine, or at least modern paediatrics. Yes, you could argue you're lowering the expectations, and I absolutely bloody am. I'm not going to find out what's wrong with your kid, but that's actually going to be okay, is kind of half the message here. But just being extremely explicit and upfront. The other time to be explicit and upfront is with teenagers. Now, teenagers don't like us, and we really don't like them in medicine. It's quite tough. I mean, if you are a 10 or a 12-year-old and you get diagnosed with leukemia, you've got far better outcomes than if you are a 15, 16-year-old diagnosed with the exact same kind of leukemia. Imagine you've had type 1 diabetes since the age of 3. Now you're a teenager, and what are the points of being a teenager? You're trying to emancipate yourself from your family group and form really solid peer relationships. But then you're different, you're wrong. You've got type 1 diabetes, you've got to piss off and have some insulin all the time, or have a pump on you. You'll go, what's that? Is it a new phone? No, it's not, it's a pump. So they don't want to have diabetes, they don't want to have cancer. They say, bugger it, I'm not participating, I'm out of here. So no, they're hard to treat. Doesn't mean you shouldn't try. And there's always the argument, like, should they stop, should I nick off the teenager when they're 16 or 18? And that's the argument we're always going to have. As a paediatrician, I kind of believe it's 18. I mean, if they come in with their work boots, their high vis, they want a work cover thing, or they've just had 3 days of meth and they're 17 and a half, like, that's probably a bit more adultish than me, because I've got to give it pulled over on the corner. But on the whole, adolescence itself is a phase of growth. Paediatrics is about growth and development, so I think it's more my bag than adult bag. But then there are crossovers in those Venn diagrams. The awkward talk. We always need to ask them about sex and drugs and that sort of stuff. The worst way to do it is how I did it for years. How you do modern medicine. Hey, I'm Mark, I'll be seeing you today. Chat, background history, why are you here for? History and complaint, background examination. Now, I actually, and this is again, the language becomes awful, I actually need to ask you, the parent, to go out so I can ask you some questions about all the sex you're having. Awful, awkward, and so we don't do it. So start with that. Hey, I'm Mark, I'm one of the doctors here. I know you come in with some tummy pain, and you're a teenager, so we're going to do it the standard way we do with teenagers. I'm going to ask you why you're here. I'm going to ask you background questions. We are going to examine you, again, the we language. We are absolutely, because we are on their team, we want the best outcomes. We're not here for no reason, so we are absolutely on the same team. Then we are going to ask the parents to go out. I'm going to ask you all the awkward teenager questions, and then we're going to get the parents back in, and they'll try and pull it all together. And with that, starting with the expectation, set the expectation so you can meet the expectation. And I'm a pretty awkward guy, you can tell. It's reduced the awkwardness. I've never had a parent complain or say no. They're actually quite happy their kid gets to say stuff without the parents sort of sitting there and keeping it down. So if you start with it, it's going to work. And again, with the teenagers, again, they're not stupid. They're smarter than us. They certainly, you know, if people want the slides, I have got business cards. My email address has got Yahoo on it, not even Gmail. That's how old I am. So that's how irrelevant I am to them. But we need to work with each other. So, how do you do it? Well, if you talk shit, they'll kind of get it. If you stuff it up, it's even funnier for them. If you, sorry, I should mention this. Don't memorise this, but when you get the patient alone, you can do the health assessment, which is all the awkward questions. And S that's not there, that really should be there on good ones, is social media. Ask them about their social media if they've got some eating and appetite and body dysmorphic issues. The algorithms push 3 times as much body content onto the child. There's whole pages and content about pro-ana, which is pro-anorexia. All of this stuff is, so I will ask all these questions and then I'll actually kindly interrogate them about their social media use. And I don't have to know about social media. Like, I'm on Facebook like a boomer. I don't have Instagram. I'm certainly not on TikTok, or whatever the next one is. But I can make it understand that although I don't know your life, I am interested in learning about it. So, how do you actually talk to them? If you try and talk their language, they're going to roll their eyes at you. They're actually now, they know more about something than you do. They are in a position of power. So if you've empowered them a little bit, because I don't know how to actually, I might be vibing a diagnosis, I might be, like my registrars now say I'm vibing appendicitis in this kid, I don't vibe. But children will vibe. They might low-key want to get out of there. They might high-key not want to meet a needle. They might think, oh, you slaved that. I don't know. But if you say this, and particularly if you stuff it up, they're laughing at you. They're now sort of in a position of power. And so you can meet in the middle. You can both meet as slightly empowered, autonomous individuals. I don't understand what their life is like. I didn't grow up with Instagram and TikTok. My stupid adolescence wasn't documented. Theirs is. Horrifying. And I don't get it. But I can tell them that, like, it's harder on you than it ever was on me. They say, yep, bloody hell it is. And hopefully they'll then tell me why it's harder. So chatting to the teenager, you don't have to understand their language. You're not going to. It's going to change tomorrow. But to demonstrate that you have made some efforts about Instagram chat, and you just want to know about them, means the efforts you've made to understand a bit of their language and their world are the efforts you're going to make when you are sitting there listening to them directly with the parent tucked off in the waiting room. All right, so the talk gooder a bit in paediatrics. Parents just want you to get it. They want you to understand how special their child is. And you do, but they really need to understand that you get it. So, firstly, non-verbal cues. To a child, we look like this. We are terrifying, horrifying creatures. And they've already come. They're already sick, they haven't slept, they've gone into the car, they've gone into this weird building, or the back of the ambulance, and the back of the ambulances are generally freaking cool places for a kid. But sometimes they're bad. They might have a mask on their face, they've gone through these weird things, and then we walk up and we're like this, we're massive, we are awful things. So, just kneel down, just get down, low. The parent, the kid, if the kid's still screaming, that's unfortunate, but the parents appreciate the effort. And if the parents like you, the kid likes it, the parents like you, and so the kid will eventually, hopefully, like you. It's not a popularity contest, but if they like you, they are absolutely 100% more likely to participate in the plan that you've agreed upon together. All right, so what do parents want? What do they really want? Firstly, we, again, I've said it all the time, I'm a first talk of the conference, I'm telling you to stuff everything up all the time. Evidence-based providers overestimate their ability to communicate effectively. So just don't think you know it or you don't. I don't. I'm way too old to know. For a lot of my training doctors, they come into a busy ED, they feel like they should be efficient, and so they go in really quick, really efficient, and they've just kind of gone in too quick, don't ask the right questions. My view is, and I'm allowed to do this as an old man, I feel this actually saves me time. If I sit down for 30 seconds and sit down low with the kid, with the family, and try and have a bit of an introduction, set the expectations, it might be soft, but I save time down the line. Like every half minute or minute I take at the start, I save in the disposition and the discharge planning because they are ready to listen. And half of the plan has been worked out during the consultation as a collaborative process. So there's a lot of reasons why we get it wrong, but again, we can get over these very just subtly and sensibly. And if you sat down, we sat down like this was a workshop sort of thing with not all of these chairs between you and I think we'd all have these exact same things noted out on the big butcher's paper on the wall at the end. So, can we do it with a bit of evidence base? Actually, we can. There's two good studies. I love this study because it actually experiments on the doctors, not on the patients. There was an American inpatient study, and in this one, standard position for a chair in the room is in the cupboard, and then the experimenters just got the chair out. That's it. Chucked it next to the bedside before the ward rounds. Where the chair was out, doctors sat, because we do like it. I'm old with bad knees. They sat down 2/3 of the time. Did they get the chair out of the cupboard? Less than 10%.
Now, these TASH and HCAP scores are very American scores because, of course, you have to have satisfaction scores with basically the money, basically the American system. But they show that when the doctors sat down, the parents liked them more, or the patients like the doctors more, and if they appreciate you, they like you more, they think, I like him because he's on my team, and he wants the best for me as well, and so they participate higher. Okay, but it's an American inpatient context study. We're emergency workers. Well, there's an emergency version. Just put a little stool in each cubicle, and sitting at any point made the caregiver, the healthcare provider, seem nicer, more efficient, more informed, and the patient more cared for across all metrics. Doesn't matter how long you sit down for, that you just try it. And with paediatrics, if you kneel down, shit, if I see a medical student with plants on their knees, they're actually trying to kneel down in front of a family, I'm like, mate, you've done it well. I make noises when I get up, it's unavoidable. But anytime you get down low, sit in a chair with a family, kneel on the floor in front of a kid, it's going to absolutely help. And it takes nothing, but it really makes an impact. It's the softest, smallest thing, but it's evidence-based, and it really works. All right, I can get this done in 7 minutes. Fine. 6, me in the middle. Jargon. Why do we use jargon? We use it because it's our common language. We speak efficiently to each other. We talk about, we might give this PRN, or that'll be a TDS thing. We'll just give some prophylactic antibiotics. What is prophylactic? It doesn't mean condoms. So we use this jargonistic language because it's how we think, because it's how we're trained amongst ourselves. And sometimes we will use jargonistic language when we want the family. We are trying to emote that I know what I'm talking about. I've studied this. I know this. I have applied the years of training to your kid and to you, and I want you to believe that I've got this. But if you use words like, oh, we'll just use the antibiotics prophylactically, and TDS will get these medicines on board, and just give it PO, the parents don't know what you're talking about. They think you're speaking over them. It doesn't come across as, please trust me. It comes across as, I don't care if you understand this or not. And it creates an absolute wall. It is a barrier between our communication, our intent, and the impact. They do not, patients hate it. And so they should. It is lazy. It's our easy communication to ourselves and amongst ourselves, but it's not the right way to talk to a family. All right, so to me, jargonism it's not, I know what I'm doing, because, I'm old. It's, I know what I'm doing, I don't care if you understand it or not. It's a language of exclusion. It's really, really hurtful. So when we do it, it snatches defeat from the jaws of victory. You can have the best plan in the world, you execute it with jargon, and you've ruined it. And then when the shared mental model, again, it's a bit of language, when the shared mental model dies, so does your mental plan, just down the absolute tubes. So when possible, just absolutely use this common language. Try to explain to your granddad who works, like for example, I try to explain to my father who works on a farm, and if it's not tractors or cows, he will not get it. So I have to try and think of him when I'm chatting to families. All right, so premature reassurance, I did mention at the start. If you see a kid and they're eating and they're drinking and they're walking around, there's no neck stiffness, they've got good gait, like, I know this kid's fine. I know this kid's fine, but the parents aren't in your ambulance, your urgent care centre, your ED for no reason. They are properly worried. So you go, oh, he's great. No, he's not, he's sick. We know he's not sick in the way that I have to do a lung puncture or admission or IV antibiotics. But if you just go, hey, cool, fine, again, you've attacked that brainstem, reticular activating system. Their sympathetics are off, their cortisol, adrenaline's firing, lizard brain comes out, and they will hate you for it. So premature reassurance, again, it takes a minute to go, cool, I get it. What are the good signs here today? What are the green flags? Eating and drinking is brilliant. Next movement, face is moving, everything and all the signs point to, thankfully, just a simple viral infection that he or she will get through. That takes 30 seconds. But it's become collaborative, you've shared your mental model, you've shared your conclusion and how you got there, and you haven't just gone, hey, he's fine, no worries. Because that always comes across as dismissive. Okay, we want to do it, we want to get reassuring straight away because we're happy with the kid, we want the family to be happy. Do it too quick and no one's happy, unfortunately. So if you need to spend a minute and go, what's your biggest fear? Again, not what are you worried about? I deal with patient complaints in my hospital and a few of them go on. The doctor said, what am I worried about? And I can see that they weren't really trying to drill down to the parents' primary concerns, but again, it came across badly. So I like to say, what are you most worried about today? It implies that all of your worries are there. I get that. They're valid as hell. But if we were to talk about one right now, what's your worst one? And then you can talk about that. And let's go, what you worried about? You know, again, it's dismissive and it doesn't work. So a couple of questions, a minute or two at the start saves you 3 to 5 minutes at the end. Really, I feel this saves time. So I'll finish off with 1 minute to spare. So yes, talking good is not just a thing. It's understanding what the parents are after, that they are so tired, so stressed, they don't want to come to hospital, they don't want to be there, they're there for a reason. Inquire gently, with simple expectations and very clear, simple language. Again, this is not that hard to do very well, but it's so easy to stuff up at many stages along the way. Sorry. But when we get this right, what are we most worried about today? A lot of we language, no I language, and no jargon language. Take a little bit of time at the front, and the back end writes itself so quickly, and then you'll absolutely get through it. With 30 seconds left, I'm happy to have a question.
Any questions? Oh, right.
This is super easy. We don't have a lot of stools in my ED, so I typically go to one knee. Is there any evidence that one's better than the other?
So going to one knee instead of sitting on a stool, is the left or the right better? I'm sure it's fine. Oh, it's nearly better than. I don't think there's any evidence. I think any and every effort. I kneel as well. We don't have stools in my ED, so I always sort of get down with a little one or like this, sitting on my bum, and then I have to generally get the elbow on, make the noise, and kick off the legs. And unfortunately, it's only getting harder. But I still make the effort to do it because honestly, that's one of the things that makes it so. Apart from bribing kids with balloon animals, just kneeling down. Again, it saves me time, and it gets so much non-verbal communication done that I still will absolutely do. I might take to wearing carpet sort of knee pads down the line, but right now I will absolutely just get down on the knees. And I think, although I don't think there's any evidence about one better than the other, I think it would be as equally effective.
All right, let's hear it from Mark. Thank you, Mark. You absolutely slayed that. Is that yep, excellent. And Mark will be part of our panel discussion tomorrow. So if you do have any questions, you didn't have a chance to raise your hand there, because we did rush through. Keep an eye out, because I will put up the QR code in the break. Feel free to scan that, or if you do just have any general questions at all about your work, medicine, life in general, scan the QR code. You'll then have a chance to put in your question, and hopefully you'll have time to get to that tomorrow. We're going to take a really quick break, so let's take 5 minutes. This will be the only break we have this afternoon. Our final presentation does have some interactive questions, so if you haven't yet connected to the Wi-Fi, probably a good opportunity to do that now, and we'll be back here in 5 minutes. Oh, you're getting it? Yeah. That's what I'm saying.
Do you reckon that's just not? Do you reckon just keep it as is? Because it was really painful.
Hey guys, just because a few people have asked me, I'm a holder. There is water. It's just up the back here, so no water in where the food and tea and coffee is. You come straight off the mountain and up back. Yeah. Thanks guys.
No, but totally worth Never been.
Whoa.
Yeah, I'll go to the black.
Yeah, I was like,
yeah, exactly. Like I had just yeah, for sure. Yeah, it was 50 hours.
Not be easy just to stand here.
No, Island. North Island of Mexico. Ah, right. My bad. Terrible. From the UK originally. Yeah, I just like.
Otherwise, I need to say. It looked like they're really no sounds, like what the last one was. Excellent, no, thank you, that was brilliant. Any questions? Thank you. See you tomorrow morning.
Oh, thank you. Okay, contents are just contents were complicated.
You guys are really good at lowering the volume in the room, so thank you. It makes my job much easier, and thank you as well for the quick turnaround there. As Olga did say, sorry, we didn't realise there was no water in that area, but we do have the water stand on this side here. Plenty of space in the room, so if you are struggling to see on the wings there at all, lots of space in the front. I promise you won't get picked on if you sit in the front rows, so it's usually a safe space. Straight into the next one. So the structure now is that we'll have our last two presentations that will take us up through to the end. So once again, please feel free to move around. Apart from that, please make Jessie feel nice and welcome as she comes up to the stage. Thank you, Jessie.
Hi everyone, my name is Jessie. I am currently completing my PhD in the empowerment of early career nurses. I've written a few pieces for AusMed recently on a similar sort of topic, and this is one that really resonated with me. So I'm going to be talking about early career nurses, but specifically novice and advanced beginner nurses. This is going to be talking about their experiences providing end-of-life care in emergency and acute care settings. So for clarity, when I say novice, I'm referring to those nurses who are newly qualified, but still heavily reliant on the people around them and the circumstances that surround them and the experiences that occur for them. So they're still really heavily relying on those learned rules, step-by-step guidance, documents, policies, all of that sort of thing. Advanced beginners are those who have been in practice for long enough, though, to start to recognise those emerging patterns. So what's happening for them in their workplace, what they need to be doing. The reason that I think it's so important to be looking at novice and advanced beginners is that we lose almost as many nurses in our second year of practice as we do in the first. Recent research is demonstrating that time and time again. In Australia and globally. So it's really important for us to look at not just what happens in that first year, but also what happens in the second year of practice. This is particularly challenging for nurses in the ED, because this is where they encounter those critically unwell patients. Unexpected critically unwell patients too. They don't know what's going to come through those doors. So it's really important that we can look at these situations through their eyes, through the lens of a new nurse, so that we know how to best support them. This is about supporting not just the nurse as a person, but also their development. So not in abstract, but grounded in real case, with their real emotions, and real clinical realities that many of us would have lived through as early career nurses. So there are a growing number of older patients presenting to the ED. As we all know, we are an ageing population. But why does this matter? Universities typically provide really good, strong, therapeutic, palliative care education. But that tends to more talk about the ideal situation for palliation. So we look at the quiet room, the private space, having family at the bedside, music, massage, all of those sorts of things that are really important. And very much evidence informed. We know what makes a good palliation for our patients. What students are usually taught, though, reflects that idealised palliative environment, but not what tends to occur in the emergency department and also in acute care settings. So although these controlled scenarios might resemble the reality of what we want to have happen for our palliative patients, it's not what actually resembles the reality of end-of-life care in the ED or in acute wards, so we're talking medical surgical wards. When novice nurses enter the ED for the first time and then they palliate a patient, this is often not in the context they expect based on what they've learned during their university studies. It's usually in the context of loud noises, alarms, lots of people around, family not at the bedside. It's not generally what we expect as an early career clinician. So think back to what you were taught during university. Was the first time that you experienced a patient death, if it was in the ED or in an acute care setting, what you expected? Did you know everything that you needed to? Obviously, if this occurs for you during a graduate rotation or early career in a palliative care unit, then maybe you were well prepared. But I'm thinking that maybe a lot of you can think back to your first patient death and that maybe there were some elements of that you weren't completely prepared for. So when these experiences occur for early career nurses who have had some university preparation, in the sense of what makes an ideal death, I suppose we can think about how sudden this might feel, how unexpected, how emotionally overwhelming, and how early career nurses can actually start to think that they're not as prepared as what they hoped they were or as what they thought they might have been. So the ED realities for a new nurse. This is fast-paced, it's noisy, it's unpredictable, it's often chaotic. There is limited privacy. We've got patients with curtains between them, in quite close proximity. We've got patients in waiting room. They could be in waiting room for hours. These patients then might be very quickly moved up to an acute ward, or maybe not. Maybe these early career nurses remain caring for them while they are in cubicles divided by curtains. The ED in particular, if we focus in on that, is designed for rescue and escalation. It is designed for these nurses to feel as though they need to escalate care. Something's happening for my patient. What can I do to help them? What do I need to do to save my patient? That's what these nurses are taught. So we're looking at how to rapidly assess our patients, how to escalate these patients' needs, but we're also looking at interventions and patient flow. How quickly can we get our patient up to the ward? This is often chaotic with limited privacy. But what our nurses, what our early career nurses are not expecting is that they're not going to get that patient to the ward. That they're not going to be escalating this patient's care and intervening in a way that is meaningful to help support this patient to recover and thrive. They're not expecting their patient to die. The physical and cultural environment of the ED intensifies these challenges. ED is geared towards rapid assessment, intervention, patient flow. We've talked about that. It is a space for constant flow of patients. We're just getting them in, we're trying to get them better, we're moving them on. The interesting thing is, though, that we're actually shown through research how many patients come into the ED and we're never going to survive. But these early career nurses don't realise that. So a lot of this research you can see on the screen was actually very recent research from Australia and New Zealand. So that's demonstrating, current statistics. For early career nurses working in the ED, this means that encountering a dying patient or a patient who will die imminently is a part of their routine emergency workload. New nurses need to manage not only clinical care, but also the communication with family, symptom relief, ethical considerations, cultural considerations. There is a whole host of issues that these new nurses need to be able to navigate during a time that they're really just, they've never done this before. They're not necessarily prepared for this. We don't really prepare our new nurses for palliation in an ED setting, in a cubicle with curtains, without family. So for those who need to actually take on that emotional weight and step into these complex situations with limited preparation, they're looking to everybody else around them to help support them through that. Over half of our older patients that come in through the ED already have unmet palliative symptoms, care needs. They might have already been at home with a lot of needs that have not been met maybe by their GP. They might be in an aged care centre and really not having those palliative needs met. Their day-to-day ADLs are being met, but maybe this patient should have already been palliated before they came into the ED. For any of you who have worked in ED settings or worked in acute care and taken care of patients that have come from a residential aged care facility or from home and maybe their families already weren't coping, I'm sure that this is going to resonate with all of you, that a lot of our patients already really needed palliation care prior to coming in. And palliation doesn't mean that we think this patient is going to imminently die a lot of the time. Obviously what I'm talking about today are those cases, but we're thinking about patients who could have been on long-term palliation with pain relief or symptom relief before coming into the hospital. many of these patients already weren't linked in with the services that they need. And what that means is that then when our patient does come to us and they're very clinically unwell, they're very frail, and they're left with an early career nurse who is, like I said on the slide previously, thinking that they need to escalate care and take care of this patient. They're watching the observations. The issue with that is that this patient already wasn't well. So they really should have already been linked in with those services. That also often means that these patients don't have advanced care directives as well. And so therefore, a lot of these nurses encounter these cases with limited preparation. So what does end-of-life care actually look like in an ED? It looks similar to anywhere else. It's just that it is in an environment that is not catered traditionally to end-of-life care. So think back to that early career nurse. You as the early career nurse, and now you're in the ED and you've got a patient, and this patient is unwell, they are deteriorating, and you're thinking about all of these escalation trajectories that you know, that you've been trained for, that the last few months of your rotation have set you up for, what you need to do for this patient. However, this patient actually just needs comfort measures. They need pain relief. They need to be repositioned. We need to avoid pressure injury care for them. You know, there's all these things that we need to do for this patient. Oral care, we need to contact their family. We need to see if there's any cultural considerations. But this is not what we were geared up for. We've spent a couple of months now working towards getting this patient into resus, or getting this patient to theatre, getting this patient up on the ward. Quick, let's move on. Patient flow, you know, we've got patients waiting that are ramped that needs to come in. Those fundamentals of dignity, privacy, making sure that this patient's best wishes can be met are not being met. We're not slowing the clock down. We're not actually making sure that our patient is getting a good death. And the responsibility of all of that is falling onto our early career nurses. So, like I was saying before, we've got an ageing population. We can see the statistics on how often we're having patients dying in ED, on how many patients don't have their palliative care needs met prior to coming into the ED. So if we've got all of these patients coming into the ED, and we've got early career nurses in there taking care of them, there's a very strong possibility that these early career nurses are going to encounter their first death in the ED. And if it's not in the ED, then it's going to be that patient that was very quickly sent up to the ward because it was recognised we couldn't do anything. Suddenly there's a graduate nurse on an acute care ward. Not even a graduate nurse, I'm talking about novice and advanced beginners here. They may have even already had a death before. This presentation is about the first death, but maybe it's not. Maybe they've had a few deaths on their acute care ward that were reasonably well set up. You know, the PAL care team came in and helped them out. But now this patient suddenly come to them from ED because it was recognised they weren't going to make it. And so this may not be their first death, but it may be their first unexpected death. Patient comes straight to the ward, already deteriorating, already needing palliative care assistance. It didn't happen. This is what happens. The emotional burden on those nurses then, as an early career nurse who either hasn't encountered death before or wasn't expecting this death, is huge. We're talking about an average age of 21, 22, 23 years old. Maybe have never come across death before. We're thinking, I'm working in the ED, I'm working in acute care settings, I'm not going into palliative care, I'm not going into aged care. Suddenly struck with death. Death in the ED, death in the acute care settings. And I know that this topic is a little bit taboo. And when I first wanted to write about this for AusMed, I was actually met with, is this psychologically safe? But this is a reality, isn't it? It's a reality for early career nurses. So we need to make it psychologically safe. This is a part of the job. Strong memories for these nurses are what helps to then shape and form their future practice. I want you all just for a moment just to think while I'm talking about your first patient death. Did it stay with you? Did it stay with you for a while? Does it still stay with you? Did you wish that you'd had further support, better support? Did you wish that you knew what you know now to help support that patient, their family, and yourself? So this is just a little bit about why I feel it's so important to focus on novice and advanced beginner nurses. This kind of shapes a little bit of what I'm talking about in my PhD as well, and a lot of what I write comes from this. So this is Bange's framework. Essentially, Bange's framework for novice to expert is a really good way of looking at the nurses that you're working with, looking at the nurses that you're supporting, and seeing what they really are up to. Where are they at? Where are these nurses at? When you look at novice and advanced beginner, this is your, 0 to 2 years. And right now, this is the biggest cohort of nurses that we sort of have working in acute care, because as I'm sure a lot of you would know, we're losing a lot of expert nurses. So, this stage 5, this is sort of going out the window a little bit since COVID anyway. And we've got a lot of junior nurses, and if we want to look at retaining them and increasing their role satisfaction and increasing their support, and then having them go on to be the future generation of nurses that are going to support everyone else after that. Think about your children, your friends' children, your grandchildren. If they want to go into healthcare, it's these nurses now in novice, stage 1 and stage 2 that are going to help to support them. And they are also the ones that we're losing at an alarming rate in the first and second year. So, as the slide says, they're the ones who have that really strong need for mentorship, support, and experiences that are well supported and debriefed and talked about. So the system and structural barriers here, like we've already talked about, is, ED is not really an environment that is suitable for dignified dying. It's not set up well for it. So what can we really do here? We know that there is a higher workload. We know that there is a lot of staffing pressures. We know there are competing priorities. If you are in the ED and you've got 3 patients and 2 of them are young and quite unwell and you can escalate their needs, those are going to be competing priorities for you when you've got a 3rd patient that is maybe needing palliation. There is also a lack of access not only to what your patient might already have documented for advanced care directives and things like that, but also you might not have a palliative care team available to come and see you and to come and help you with your patients. So we know that. We know these system and structural barriers. What can we do then to help support our early career nurses? So for me, this is what I suppose sort of guided wanting to talk about this. I personally didn't do a grad year. A lot of nurses don't, although obviously it's more common to do that. I chose not to do a grad year. It didn't suit my lifestyle at the time, and I went straight in as a casual nurse. I was in the ED within about 6 weeks, and that's where I encountered my first death. And so for me, I can really think back to everything I'm talking about right now. I had minimal guidance. I didn't really know what to do. My patient died and everybody around me seemed to just move through it. Everyone around me was calm. There was no instant debriefing. There was no talking it through. It was just, well, have you done this, this and this? Since then, moving into clinical leadership, I'm currently working as an educator, doing a PhD on early career nurses. I now understand how important it is for us to help these nurses to thrive, to empower these nurses and to support them. Even if you're not worried about the future of nursing in this situation, in potentially facing death in the ED or in acute care settings, we also need to think about ourselves as communities. What would you want as you age? When you come into the ED and you potentially need this help at your end of life, what would you want? What would you want the nurses around you to understand? How well supported would you want them to be? And the reality of it is that a lot of us will encounter moving into the ED and needing this support around us. So we've talked about what good end-of-life care looks like. But what can it look like in the ED? We can still encourage early career nurses to understand the importance of all of those aspects that they've learned about in university. They've learned about how important it is to give these patients dignity, privacy, contact their families, to find out if there were any advanced care planning documentation, or if there even just was things that they might have wished to have had. We also can teach these early career nurses that we need to contact their aged care facilities or whoever they have been living with. Find out what's important to these patients. We need to create environments where not only are these patients getting everything that we can potentially offer in the ED and in acute care settings, but also create environments, as experts, with all of you here, we all need to work on creating environments where our early career nurses know the importance of that. If you've got 3 patients and one of them is needing palliative care treatment, what is the importance of that? Each patient only gets to die once. So if we can help our nurses to understand what they can achieve in the ED, that makes a huge difference to a patient, their family, their friends, their loved ones, and the nurse caring for them as well. What they need to thrive in order to provide all of that. They need structured supervision, mentorship, team debriefing. If you've got a young early career nurse working with you and they've got a patient who is unwell, what can you offer them? What can you tell them? What can you teach them that could be very important, not just to them as a nurse, not to the patient they care for, but for the future of nursing? What are they going to take on board from all of this information you give them, from this palliative training, realistic expectations? They need to know when to move from cure to comfort. Are we teaching them that? Are we setting them up to want to remain our colleagues, to want to move forward and help to support future nurses again? We need to teach them that it is just as important to use emotional labour as it is physical labour. What can we do to help support our patients and their families? They need to understand that everybody around them, all of the doctors, nurses, allied health professionals working around them also appreciate the importance of any emotional labour that they put into these patients. End-of-life care is actually a core ED concept. ED and acute care, I like to look at both of those situations because I think, like I said before, often a nurse might also just have a patient come straight to them up to the ward and they already don't know what to do with this patient. I think it's really important that they understand that this is a part of everyday practice. It's not an exception. It could be your first death while you're working in the ED, but this is going to happen. It is going to happen a lot, especially with an ageing population. I think that early career nurses need structured support. They need structural empowerment. They need organisational empowerment. We need to, as people, we are a part of the organisation that work with them. We need to provide these nurses with empowerment. We also need to build them up so that they can use their own intrinsic understanding and psychological empowerment to help support their patients, care for their patients, and care for each other. Create an environment where everybody feels as though they've got some autonomy, some understanding of what they can do for their patients. I feel that for anybody working with early career nurses, whether that be in the ED, in acute care settings, should really invest in understanding what we generally teach these early career nurses, which is, you know, like I said before, we teach them that they need to escalate. Absolutely, of course they do. We don't know a patient needs to be palliated until we know it, right? They need to understand that they need to escalate. They need to understand how to intervene for these patients. But they also need to understand how they can provide safe and compassionate care once we do move from cure to comfort. So I think that for anybody here who is working with early career nurses, it's really important that we understand that we don't just continue with professional development in the way of the latest care for our patients or the latest you know, care trajectories, care pathways, looking at professional development from a clinical perspective, but also that we look at what education we can commit ourselves to that is going to increase the culture around us. These are going to be the colleagues that will be there to support you when you need them most, but also they're going to potentially be the healthcare workers that are going to be there to care for you and your loved ones. Thank you.
Thank you very much, Jessie. Just while I quickly flick over to the next presentation, does anyone have any questions?
Yes.
Big voice?
I can present a big voice.
Great.
Great. Just a quick question from a pre-hospital perspective for your team. We're sort of in a similar boat as sort of paramedics, and we try to keep patients at home as much as possible, particularly the palliative ones. Is there anything from the ED perspective that we can do more so at home before bringing them in? Is there different information? Is there any specific needs that would help them more in the ED if we have to bring them in?
Look, I think that obviously, thank you so much for your question, for starters, but I think obviously, as you would know, it really is very case dependent. If you've got family there with you when you're bringing a patient in, you're going to be able to establish whether or not you've got that documentation behind you, whether they've got anything else that they need, what has their life been looking like prior to that. I think that it probably is everybody around these early career nurses. I think it probably is the handover from you guys to ED. How thorough is that? What do you know about it? What questions have you asked about this patient from a psychosocial perspective as well? And then ensuring that that information gets handed over to the nurses. So I think just any information that you can gather on this patient prior to bringing them in is always going to be valuable. Thank you.
We had one more question as well.
Yeah, just from a perspective of doctors, what's kind of your advice for how doctors can support nurses to early career nurses?
Yeah, so that's a great question too. I think that doctors definitely can have a huge role to play here, and I actually work as a medical education officer, so I work with early career doctors as well, and I think it's communication. It's communication across the board. If your nurses come to you with any concerns at all, that's a time to, you know, obviously everyone's busy, but that's a time to try and review the patient in person and see what we can possibly do for them. Maybe ask the nurse if they have spoken to the family, or if they have looked over documentation, have they looked at what has happened to this patient prior, especially if they have come from residential aged care, because that can save time for you, and it can also help the nurses to get a stronger picture of what has happened. So I think encouraging them to really dive into the patient's background before we either look at escalating or starting to move towards comfort measures.
All right, I think we're out of time now. Let's hear it one more time for Jessie.
Thank you.
That brings us nicely on to our final presentation of the evening. So, all our presenters actually tonight have actually presented before, so a huge thank you to them, including Willem, who presented for us last year here in Queenstown. So let's hear it for Willem as he comes up to stage.
Hi everyone. I'm kind of interested to find out before I get started, because this is a mixed group, right? So we've got nurses, paramedics, doctors over here. Who here is a doctor? Okay. Nurses? And paramedics? Awesome. Okay. That's great. Hopefully you'll find something useful in what we're going to go through now. The way I've set it up is to, I guess, get a bit of the honest feedback bit at the front end, which is going to use Mentimeter. So if you get your phones ready, I think we can at least be a little bit more honest in anonymity by asking, I'll ask some questions about difficult patients. And I kind of figure most of us that work in this space, when you think about a hard-to-sink patient that comes in, you go to, you see, you know what I'm talking about. To start off with, if you just do this one, I just really want to know how that hard-to-sink patient makes you feel. It might be on the whiteboard in an ED, or it might be the RT going off and it's a patient you already know as a paramedic. A nurse, you might see them walk in and your heart sinks. Yeah. Right. I think we've all felt a whole lot of those emotions when we see these patients. I was expecting some more colourful language to come up. There's some, yeah. Thanks. Can you just take a look at this and just what are some of the underlying drivers why you feel that way or those ways? If you just take them into here, just score and there's a whole host of other reasons that can affect us when we see the heart sink patient. But I just chose some of my favourites as to things that I experience. And one of them kind of I'm going to suggest that one possible reason is because of our professional script. We fixes, and it's if we think about emergencies, this kind of, you'll have a script something like this, right? And actually, for all of us that are here today, I think this is what drew us into our profession, to find this stuff and to be able to help. And I don't think these patients are fit into this. Not for me. I think we can all recognize what the consequence is of us operating in the way that we operate. We get what we get, right? And you know, those of us that have been around the traps, we certainly recognize the need for more junior people to order more tests, do more things. But you kind of get this sense of frustration, because like, what the hell? What can you do in this situation? Can you make any difference at all? So the feeling inside us is actually, I guess, a sense of disempowerment, frustration, We don't have the solution. Some of you might. I'm starting to get a little bit better at it. But here's the big question. Have you ever thought why this patient actually comes to the emergency department? Now, the patient that you guys thought about to start off with, I'm going to pick for most of us, most of our examples, it's going to be a frequent flyer patient, someone that comes in frequently. And yet they come in even though you know and they know that nothing can happen. What the hell's going on here? Why? And I think that really gets to the heart of the issue if we get to that. And Mark actually mentioned it in a different way in the first presentation. Most of these patients, most of these examples that you thought about, live with something to some extent every single day. Might be chronic pain, they're in pain all the time. There comes a point where the usual coping mechanisms are overwhelmed. And something breaks, a straw that breaks the camel's back. Something's happened that's walked in like that. And even though they've probably had a bit of a shocking experience most times that they've come to the emergency department, but they're still being called the ambulance. It would be the same. It would be the same experience for them. Yet they're desperate enough to do it again. So I think it's a really useful vantage point to sort of understanding what it means from their experience. My parents, my father retired about five years ago. We live in Auckland, and he moved up to Bange, North Island, so it's beaches and sunshine over there. I'd say it's more like special information for those that are concerned. We went to go visit them, and we took our dog, and the one day we needed to get some stuff in town. It was actually at a bookshop, and we went there with our dog. And being a good citizen, I had the dog in the lead, and I waited outside the shop. I went back inside the shop with the dog, Labrador, beautiful Labrador. This guy came, he's a Somali warden, 6'2", massive guy. He came up to me, and so he didn't look me in the eyes. He kind of came to my side, and he just looked down at me, and he said, "Hey, Ron, are you from around here?" So I said, "No, I'm from Auckland." He said, "Oh, Auckland, that's amazing. Does all of your family live in Auckland?" I said, "No, I'm visiting my parents. They're over here. They've moved to Bange." "Oh, how long have they been in Bange?" I said, "Oh, it's been a year now." "Oh, that's absolutely fantastic." "Oh, is that your dog?" I said, "Yeah, that's my dog." "Oh, beautiful dog, man. That's wonderful. How long have you had your dog for?" She said, "Well, she's 10 years old now, but we only got her when she's 1 year old." I said, "Oh, I know you're not from around here, and you've got this beautiful dog, but I don't know if you realize it, but this is a dog-free area. But don't worry. Take your time. You're good. Take your time. But just so you know, it's a dog-free area." I think that's like one of my best customer experiences I've ever had. Eh? Can you imagine being a dude that had to tell someone to piss off because they brought a dog into a dog-free zone? Okay? How skilled was that? I felt good. I left straight away, by the way. How can you not? How can you not leave straight away? But I felt good. I didn't feel bad. He didn't feel bad. We connected. And and I did what he wanted me to do. He could have chosen to have a different sort of a job, and he would have, he's big enough and whatever to actually achieve it a different way, but he didn't. So I'll make it really simple for a little bit of a formula for patients that come in. The 50% of the game is validation. 50% of the game is validation. So don't start off with anything else. You just pour, if you can stand it, empathy. So what I'm saying is, I get this feeling and I go, oh, shucks, it's one of these patients again. And they go, wait, okay. And I just get myself centered before I go into the room, focused, okay. Then I go into the room, I do what Mark says, I get a chair, always make sure I've got a chair, and I sit down, and I introduce myself to the person, as we all do, and then I say, must be really bad, because you're in the emergency department, and I know you don't want to be here. What's going on? Tell the story, let me tell the story. Oh wow, that must be really bad. Just keep it. Now the trick is that I never agree to BS, okay? But what I'm trying to do is validate their story. That prick from Auckland, he's in my dog park right now, dog-free zone. Just validate their story first. So I connect in that way, right? And it's absolutely amazing because their experience is of my former self when I used to deal with patients like this normally was to try and get rid of them as fast as possible. But starting off with an empathy to realize that they've come in overwhelmed for a particular reason, and just being okay with them being in discomfort for a moment is just absolutely gold. Don't be shy of time with this. Don't be shy. I know it might feel like a century. It's seldom going to be more than 5 minutes. Maybe it's 10 minutes. But you all know how long these patients stand up in the emergency department if you don't deal with them properly from the get-go. So like Mark's abdominal pain, start off right. This is something you sit down and you're just going to throw the validation, the empathy, shower them with empathy. Not BS, by the way, don't do that. That comes next. You can choose any statement that you feel works for you. This is one that I use. I'll stop using the mentee at this stage because I figured you guys would be getting bored. Very, very, very different framing of the same problem. Okay? So you're just choosing an empathetic stance. It makes all the difference. Okay. The B of BS. Boundary. So the most work, the most success that you're going to experience with these patients, this group of patients, cohort of patients that we're talking about, is going to be because of the first part, right? The showering with empathy. This is the heavy lifting part, and it can only happen if you've done the first part. You're going to get through some patients who won't need to do anything else. The second time I tried this approach, after saying, oh, it's so bad, whatever, nothing ever works for you. Oh, it's different. How do you hear if nothing ever works for you? It's like, oh, well, that's terrible. And then there's silence at the end, and she said to me, hey, doctor, is it okay if I leave now? Sure. Do the discharge paper straight away. But this is, most people, you'll have to go into boundaries, okay? And a boundary is about what you can and can't do within the environment. That's the boundary that we're talking about. You need both. What I can do is this. What I can't do right now is that. And this is just like what is realistic in the situation. What I can do is always diagnose abdominal pain. It's not going to happen. What I can do is make sure you don't have a dangerous cause for your abdominal pain. Okay. When you say I can't, give the why. I can't give you morphine because it's not indicated for someone who has recurrent abdominal pain. If that's whatever the response is that you take. Okay? Luckily, I don't have that many patients in New Zealand that demand an MRI. But when they do demand an MRI in New Zealand, they're definitely in a special group of patients. This is the S of the BS in the middle of the sandwich. It's very simple in the sphere that we work, right? We're looking after things that are potentially life and limb threatening, and we're really good at that. And we can be honest about that with our patients. We can look at relieving suffering to the point of where it was before. Because they live, if that's the reason why they're with us, because they live with pain. Do not pretend that you're going to cure the patient. You're not. You're not that good. None of us are. And then you've got to say to them, once I've done these things, I'm going to make sure that you're safe, physically safe. I want to help you with this thing, with whatever is reasonable in terms of the help that you can offer, if it's reasonable. And then you say, I will help connect you with the next part of your journey. If that's unknown, that's the next thing that's going to happen. But I'm saying that up front. This is all before I've done anything else with them. I haven't asked them how long or whatever they've had a particular thing. This is just framing up what happens next, and in which that biomedical model is going to happen. It's as simple as that. This is the last part of the journey, right? So, what will happen with these patients? Okay, I'm not going to pretend that this is going to work every single time, but I'm going to guarantee you it's going to work more than you doing a bunch of blood tests and trying to cure them of their pain. You start off with empathy. You give your boundaries and structures. Okay? Your beer sandwich, so you've got your little bit of white bread at the front with an empathy, your boundary and structure. And then you're going to do all of the work, like you said, with your boundary and structure. And then, when you come back, it's predicted, it's planned. Now the thing here is people who come in, most of these people that we are talking about have some sort of trauma background. We're doing a trauma-based response. It's an approach to people like this. And the difference of this approach is rather than creating certainty in a diagnosis, we're creating certainty in a structure. Rather than saying, I'm going to solve the problem, what you're doing, and you can be explicit with the person that you're dealing with, is that you're going to be consistent in your structure. Consistency is key. That's why persons like this respond well to a well-constructed management plan, is because it should be followed and predictable. Unpredictability is a killer. So you've given a predictable model and you followed it up at the end, just like you said you were going to follow it up at the end. So it's not particularly complicated to explain to a person. A typical example is chronic abdominal pain. I did the blood test that I said that I was going to do, if that was what you said you were going to do, to check for a dangerous cause of pain, just to make sure that it isn't a different type of pain this time, if that's necessary in this particular example. What I found is that there were no dangerous causes of pain, and what we can do now is safely get you back home. And now that you've got a better sense of control over your pain, you don't need to cure it, and don't promise to cure it. So those are the 4 steps, and super easy, super simple, super practical. If you've never done this before, I promise you, absolute game changer. So much so that when these patients come on our whiteboard and they come up, I like to go see them first. So from patients, the patient groups that are avoided, these are now patient groups that I run towards. It's a different approach, it's a different way of doing things, but they are so appreciative of just the structure and the empathy, because I promise you, they are over it about as much as we are. Thank you.
Thank you very much, Willem. And does anyone have any questions? Yes, I'll go microphone here as well.
Hi, Willem, thanks for that. I'm a rural GP in Australia, and I'm just wondering, and obviously you work in the New Zealand system, do you sort of explore, or do the staff in the hospitals here look to see if these people have a regular GP? And if they do, where does that fit in with what happens next? Because it's very hit and miss in Australia. We have these frequent flyers. GPs have plenty of heart sick patients. We see them on our list, so we might, got all of them coming in on one day. So I think that's actually part of closing the loop, because we in GP land can do a lot to stop these people presenting to emergency departments. But we need that feedback. That's really important.
I couldn't agree with you more. I think that the true frequent flyer, call it the top of the pyramid, though to be successful in managing, or for them to experience success of the healthcare system, actually we need to have a joined up approach. So it's actually, what it actually involves is a bit of upfront work for us to actually connect with the, so what I do is I construct multidisciplinary management plans and a script that we all stick to, and then tell or discuss it with the person who it's for and explain why it's that way. I thought that totally say no, but they don't. And that's it. But it takes time to set it up. But again, for this type of person, it's a lot less time than alternative.
I just want to offer something because it was transformative to me, and I'm passing it on. I had a mentor one day as I was venting about how frustrated I was about frequent flyers, who said, start calling them loyal customers because it changes something in you. So I now call them loyal customers, and it did make me able to be more compassionate.
Right.
All right, I think it's a nice way to finish things up. Let's hear it again for Willem. So before I send you all off on your way, very important, how you can win some EMS Queenstown merchandise. Money can't buy this. We only have a limited run. So, we got lots of shirts to give away, but you need to be posting pictures to win it. So, get out there, snap lots of photos of what you're doing, load them up to the socials. We'll pick the top couple each day, put them up on the screen, and you'll get to choose which one will win a shirt. Really hot tip, get the photos in early because we don't have many submissions earlier in the week, and then we're flooded with it at the end of the week. Question? The preference is yes, but if not, feel free to send them through to us and we'll try to get them up as well. So, yeah, completely understand you might not want some of those photos up there. We have had some movie in the past that has one t-shirt, so there's a bunch, about 10 guys that we didn't have enough shirts to give away, but certainly, yeah, preference is on the public socials, otherwise send them through to us and we'll put them up on the screen. Tomorrow morning's an early start, so 7:45 we'll pick things up here. We'll have tea, coffee, pastries from 7:30. The intent behind that one is really just so you guys can just get out of here and enjoy anything that you want to do for the whole day rather than sort of worrying about rushing back. For those that do like a sleep in or a warm bed or already got a big trip like the Milford Sound or something like that planned, we will be live streaming all the sessions and the information on how to access those can be found in the info book, as well as how to win those t-shirts as well. So if you haven't seen the info book yet, on your emails as well as the back of your lanyard, there's a little QR code there. If you really like what you saw and you want to see it again, or there's a slide that you wanted to sort of pull back up and see what was on there, that can also be found the same link as the live stream. And those recordings should be up pretty shortly, pretty much straight after the sessions. So certainly they're there for your time, so you can reference back to those at any stage that you please. Enjoy the night, have lots of fun. Careful when it starts to get a little bit slippery and icy